Good afternoon, everyone. While still just setting up the microscope, I'm assisted here by Mr. Suresh, who's helping me, and Mr. Narayan on this side. Yeah, 1 second. Again, sorry for the delay. So this is a 56-year-old gentleman, and I'm doing a phacoemulsification. The rexus and the four quadrants chop has already been done using the lens AR system. So it's a low toric. We are going to put a T2, a Hoya Vivinex toric lens in this patient. Just like Dr. Shailer talked about, our choice of viscoelastic is to use a soft shell technique. So we tend to do a biman, sorry about the air there. This is viscode going into the eye. And then follow it up with a cohesive viscoelastic. I just tend to fill enough so that I can just about get the dispersive viscoelastic towards the endothelium side, because if I put a little more of it, what's going to happen is it's going to start clogging my field side port. When I do put dispersive viscoelastic, I tend to tent up the cannula towards the endothelium side, so I just targeted it that way. And once I put it, I don't tend to top it up too much during the surgery, because again, it has its spatula. Yeah. 1 second. So I'm going to do a 2.2 incision in this patient. The IOL power is 23 diopters. Okay. Can I have the forceps? So very interestingly, I've never used the lens AR system, but I'm going to be using those nubs that have been created and that were shown yesterday also so elegantly by Dr. Sri Ganesh, that they will help in alignment of the toric. And obviously, and very truly, I feel a bit of an issue with the parallax with all of these alignment systems. Okay, the rexus is free floating. That's a lovely, well done rexus. For a hydro, you have my hydro cannula, the small brown one. It's okay if it's not there, don't worry. Okay. Is there? It's okay. No need worry. Again, hydro, initially I had my reservations on doing hydro, particularly with femto surgeries, because not knowing what the air bubble is going to do. But now I am a little more confident over the years, viscoat and Phaco. So since this is a soft cataract, I'm really not sure, although the age of the patient is not too young, but I'm really not sure how dense the cataract is. Methyl on the cornea, HPMC on the cornea. My parameters? Okay. Okay, all right. Yes, thank you. Okay. So I'm going to, my first step is to do a pre-Phaco when I want to remove all the viscoelastic that's been lying around inside the eye, particularly viscoat, because again, there's a lot of air. Okay. Chop. I'll try to see if I can chop the cataract. Is it on chop? Okay. So I'm using a low flow system and I'm tending to use low IOP. So for those of you who do not use the Centurion system, there is no bottle height because the bottle is incorporated inside the machine and it actively compensates. So notice how beautiful the chop was. I'm just going to divide this one again. So once I get an occlusion, all I have to do is a slight lateral separation, and it really makes my life really easy because the nucleus is pre-divided. The idea of chop is to just get a good purchase or a good hold in the nucleus, just about enough so that you're able to cause that lateral separation, even if you're doing a phacoemulsification. So you really don't need a very high bottle height. And this is for the junior doctors who operate. You know, the higher you keep your bottle height, the more fluid goes in the eye, the more the chances are that you're going to, at some point in time, create a lot of turbulent environment. So there are 4 quadrants already there, but because there is some density, as I figured there might be some density, I'm seeing if I can subdivide it into a few smaller fragments, and then I'm ready to remove. Can I go into quadrant, please? Okay. When you're doing a quadrant removal is probably the only time when you need a little bit of bottle height, because you want to keep the posterior capsule away and you want to work in a deeper chamber. But because I have an active fluidic system, it really doesn't matter because it keeps the chamber stable no matter what. But if you have a gravity fed system, you might want to increase your bottle height when you're removing a quadrant. So once that's done, again, like Dr. Shailer brought about, we tend to turn a phaco probe sideways after we've extracted the nucleus because I can see what I'm removing and I don't want to have 100% occlusion. So the moment I hear 100% occlusion, although the machine has an intelligent phaco that it pushes the nuclear fragment away, Since it's a completely torsional alignment that I'm using, I will make sure that it's at least visible as to what I'm doing. If I feel there's occlusion, I'll just throw the fragment away with the second instrument. So again, the whole thing flips through. As you notice, the whole heminucleus is out, so I'm just going to separate out whatever little bit I can and remove the rest of the nucleus. Again, because the fluidics are so smooth, you really don't have a very turbulent environment. I'm a slow driver, so I like to see what I'm doing, and I like that control that's in my hands. No need. So there is literally no epinucleus material because the dissection was very good, and we're going to move into bimanual IA. Okay, so these are 1.1, these are 1 millimeter incision, so it's going to be a snug fit. My choice is again bimanual over coaxial because it gives me a little bit more maneuverability, and I'm just making sure there's no air in the. So as I said, because it's a 1 millimeter incision, chances are I might have to use a little bit of a force to enter, and if I still feel the same, I'm going to probably enlarge the incision slightly. Yeah. So if you can give me a yellow knife, I'll just slightly enlarge the incision. Yeah. Second instrument. Sometimes because a 1 millimeter with an Alcon knife, with a Alcon 1.1 with a 1 millimeter side port and a 1.1 millimeter, the choice is a difficult one to make, but I would prefer to keep it one as I did over here, and when the time comes for an IA, maybe enlarge it, because the smaller your incisions are, the less leakage and the more stability. Okay, so you see over here it went down smoothly inside now. Cortex. Yeah. So even if this little bit pieces, the only difference between a routine phaco and a femto phaco is getting the cortex out, so I need to go deeper and take a purchase on this side and then gently drag it towards the center. I don't aim to remove it until I come right in the center, and then also I will feed it because I don't want a certain surge. Although with this machine, hardly any surges will ever happen to you. But because the femto cuts away not only the nucleus, but when you're doing a rhexis, the cortical fibers also get cut and they get retracted. You really can't hold them here. You need to hold them a little bit deeper to take them out. Once you get a hang of it, it's really pretty much the same. I can see, interestingly, those knobs that were made for the toric IOL, and they look really nice. Okay, I'm going to change my hands. That the dexterity and the ease of being able to maneuver between both the hands in a bimanual always gives me more confidence. Okay. Sorry. Yeah. All right. So since there's nothing on the posterior capsule, I'll go ahead with an IOL implantation. Again, my choice of viscoelastic is a cohesive because I want the chamber to stay formed. I'm not a big user of hydroimplantation. I do it selectively every now and then. I load it. Yeah, toric. All right. So I'm putting a toric IOL from Hoya. This is the Vivinex toric. It's a T2 power. I'm putting a 23 diopter lens. I'll just run you through the loading. Viscoelastic, okay. So they've already put in the viscoelastic, which was step 1. Now I'm going to just remove the locking and just going to load the lens by sliding the lens into place. The one thing that I've used a few of these lenses, not a lot of these lenses, but whatever I've used, the one thing is for certain that they have probably the best injector system that I've ever used, and it couldn't be better than in terms of the smoothness of operation. But more importantly, the fact that I can now do in the wound delivery rather than doing a wound assisted delivery, which I'd been doing which I still do for a lot of lenses. So this was a 2.2 incision, and just wanted to notice how smoothly the cartridge snugly fits into it. I hope it doesn't, it was supposed to go in, but the fact that it didn't. Yeah, all right. So I think I'll enlarge to a 2.4. Do you have another lens and a backup? Or we can reload the same lens if. Can I have Helon Pro? Although the chamber was filled up. If you have it, otherwise we can reload the lens. All right, so there'll be a Alcon injector. We can, yeah. You want me to reload the lens? I can load it in Active. All right, sure. Yeah, if you can give me the 2.2 knife, I'll just slightly enlarge it. It'll make things easier that way. Yeah.
The injector has a slider in front. So if you're doing a wound insertion, then it has to be behind. If you're doing a wound assist for a 2.2, then you need to kind of push it slightly in front so that the tip just engages the wound, and then you will not have this
Yeah, that's
issue.
from, yeah.
So, yeah, for if you don't want to do a wound assisted, the technique of using this is a little different. You need to just push the slider in front so that the guard comes,
Yeah,
and
that'll be nice.
that will just help you keep the
Yeah.
tip at the incision.
Yeah. So I'm doing a slow delivery now. This is a rotational delivery. Yes. Yeah. Go ahead. Good, good, good. All right. Okay. Thank you. Thank you. Yeah. I mean.
You
Yes,
can see the textured haptic there.
Yeah.
So
I'll just hold on to it.
textured haptics, and you can see that the lens unfolds quite quickly and smoothly. And the textured haptic and overall 13 millimeter diameter gives this lens a lot of stability. We have been using this lens for a long time, and we have hardly had any rotations. The rotational stability for the toric Hoya lens is excellent, and this is my preferred lens for torics.
I think because we enlarged the incision slightly, yeah, we're in order. So again, for removal of viscoelastics, as I said, it's very easy to remove a cohesive viscoelastic. And coming to the lens, I mean, in terms of even if you look at the clarity and the ease of unfolding, one of the choices for choosing the right lens, rotational. Just want to align the lens in place. Is the quality of how the lens behaves intraoperatively. Maybe we discuss so much about how the lens performs post-operatively and how easy or how difficult it is, but the reality of it all is it has to be easy to implant for the surgeon, because if it's not easy to implant, it's never going to be a pleasant experience for the surgeon. And no matter how good or bad the optical quality is, half the surgery is the ease of implantation. And I just want you to notice how I'm using the nubs for alignment over here. This is the first time I'm using it, but it's actually not difficult at all. In many ways, it's probably better than using just a hydration. Yeah. All right. Can I have a low bottle height? I just keep the bottle height on the lower side because I just don't want to cause a sudden decompression. Okay. Thank you. So I tend to rotate my side ports first because they're generally the more leaky ones. But in this case, because I did enlarge the main port from a 2.2 to maybe a 2.4 only for the ease of implantation, I'm just going to make sure the stability is there.
Do you use to polish the anterior capsula in the toric IOLs or not?
Yeah, that's a great question. I don't normally polish my anterior capsule because in my hand it doesn't give any added benefit to the patient. Although I do understand that it makes the surgery look nicer and makes the whole surgical field look great, but I don't particularly use any polishing assembly. All right. So if I can, there's a small fiber there. I want to remove that. Can I have my forceps? There's a fiber in. Can I have my microrhexis forceps? I'd open microforceps. You have any microforceps? Yeah. Yes, thank you. I'll use this. And a spatula. It's just a small, maybe it's, insignificant, but I mean, since the fact that it's there, it's, yeah, and I'll repeat a hydro once it's done. Can I have an IA, irrigation? I'll just pull it out of irrigation. Okay. See if I can do a hydro. Yeah, it's bimanual. Let's take it out. Yeah, it's just a small little detail that. Yeah. Okay. Yeah, there you go. Okay, all done. Okay, so again, just to repeat a hydro, just to create the anterior chamber again. I'm just going to hydrate the side ports because I remaneuvered in that area, and I think with that, that's the end of the surgery. Thank you. Thanks a lot for bearing with me during this.
Thank you very much. Congratulations for your surgery. There is any question from the audience?
Nice surgery, Dr. Samaresh. Most of the time, when we are aligning the toric lens in the back, the one side of the holes appears to be in the axis,
Right.
while the opposite side appears to be out of the axis. So, how do you make sure that it is in the proper axis?
Yeah, I think that's a great question. And so for that, I learned the trick from Dr. Sri Ganesh only. I tend to align all my Purkinjes on one side. So there is always a parallax error, particularly for the distal one. So when I pull the globe on one side and I get all the images, all the Purkinje images in one line, generally both of them will be aligned. But even then, if I do have a confusion, I will tend to rely on the ones that are proximal to me to be confident that it's aligned.
So the guide is the proximal one.
Yeah, proximal one, and the better guide is to just align align all the Purkinjes, rotate the eye so that all the Purkinje images come in one line, and then even the distal one mostly will be in axis.
Okay, thank you so much.
All right.